Hi, I'm Dr. Priyanka Bansal. I'm an obstetrician and gynecologist. So today's audio I will be discussing few high yield facts about ectopic pregnancy. So we know what is ectopic pregnancy. It is a pregnancy which is outside the uterine cavity. The word cavity is important as we'll understand further. So we know the most common site of ectopic pregnancy is fallopian tube. But the least common site, please understand, it is a cervical ectopic, or now also scar ectopic is coming. That is in previous sections. So these two are the least common sites. In fallopian tube also, which is the most common site, we know is the ampulla. Second most common site will be the isthmus, and the least common site will be the intramural sites. Now I'll discuss what are the two differences between cornual pregnancy and angular pregnancy. So I had told you that the normal pregnancy should be into the uterine cavity. But suppose if it is attached in the lateral wall of the uterus, then it will be cornual pregnancy or angular pregnancy. So if it is intramural, okay, if it is in the muscle, then it will be a cornual pregnancy, and the pregnancy is actually lateral to the attachment of the round ligament. However, in angular pregnancy, the uterus growth over here will be normal, and the pregnancy will be medial to the round ligament. So this is the most common difference. That in cornual pregnancy, it will be lateral to the attachment of round ligament, and in angular pregnancy, it will be medial to the round ligament. But remember, cornual pregnancy is the most dangerous type of ectopic pregnancy. And what is heterotropic pregnancy? Now we know that because of infertility rising, IVF is also increasing. So a lot of patients can get heterotropic pregnancy. So there is simultaneously two pregnancies. One is at the normal site, that is uterine cavity, and other will be ectopic. So most common combinations intrauterine and fallopian tube. Now what are the various risk factors? Remember, the first most important risk factor will be a previous history of ectopic pregnancy. Mind you that it is not PID, but a previous history of ectopic pregnancy. Second is history of any tubal surgery, and the third risk factor will be PID. And also a word on contraceptions. Now we know that all the contraceptions basically are for avoiding the pregnancies. So definitely all will decrease the absolute risk of ectopic. But if at all, because of contraception failure, pregnancy occurs, then ectopic risk will be high. Okay. So which contraceptive will cause the highest risk of ectopic pregnancy if it fails? So first will be tubal ligation, remember. Then it will be intrauterine devices. Now we know intrauterine devices are hormonal and non-hormonal. So remember, hormonal devices, that is which we commonly known as Mirena, will be causing more high risk factor for the ectopic pregnancy as compared to copper T. And the least contraceptives which cause the risk of ectopic pregnancies will be OCPs or the progesterone only pills. Okay, so remember, tubal ligation first is there, second is intrauterine device, and third is the pills. Then, which is the most important risk factor for heterotropic pregnancy? I've already mentioned it is IVF. And in IVF, because whenever two or more embryos are implanted into the uterine cavity, one can migrate easily into the fallopian tube. Okay, and that is the reason that heterotropic pregnancy and ectopic pregnancy risk is also increasing. Now another word is, what is the outcome of ectopic? So remember, if it is in the ampulla, then most commonly the tubal abortion will happen. Second most common will be rupture, and that also it will be quite early, around 8 weeks. But remember, isthmus, if the implantation happens in isthmus, then most common outcome will be first rupture, because it is narrower as compared to ampulla, and rupture will happen even earlier, that is around 6 weeks. Okay. And it is a vascular accident, we know, whenever there is a rupture of the ectopic pregnancy. Now coming to intramural ectopic pregnancy, as I have already told you, it's the most dangerous type. Now why it is the most dangerous type? Because it ruptures very late. So the pregnancy will continue even up to 12 weeks. And whenever it will rupture, we can understand that it is the uterine musculature which will rupture. And hence lot of blood loss will be there, and high chances of patient mortality will be there. Okay. Now coming to the clinical presentation, remember it's a classic triad, that is pain, amenorrhea and bleeding. If I ask you which is the single most important presentation, then it will be pain. Because understand, pain, amenorrhea and bleeding. Same triad we see in abortion patients also. But the difference over there will be, in abortions more of bleeding will be there. In ectopic, pain component will be prominent. Okay, And remember, ruptured ectopic is more painful and it is a generalized pain. However, if it is unruptured ectopic, it will be only localized to lower abdomen pain. Why in ruptured ectopic pregnancy it's a generalized pain? Because the patient has peritonitis and nerve roots are also irritated. The nerve roots which are irritated will be T11, T12 and L1. Okay, and one very other important thing you must remember, that shock depends on the amount of bleeding. Okay, in the ruptured case also the patient can be stable, but the patient can also have syncopal attacks as well as shoulder tip pain. We know the reason for shoulder tip pain is because of irritation of the phrenic nerve. Okay, and just I would like to end here with the differential diagnosis of ectopic pregnancy. I will not discuss the management in this audio. The common differential diagnosis will be PID. How to rule out? By doing the UPT. Obviously it will be negative. Second differential diagnosis can be round ligament pain. Now whenever in a normal pregnancy the uterus starts enlarging, the round ligament will keep on stretching. Okay, and this round ligament, please understand that it inserts into the labia majora of the female. So they typically complain of a pain radiating from the abdomen to the labia majora. So that is a typical history for round ligament pain, and of course it can be ruled out easily on sonography. And acute appendicitis can be another differential diagnosis because those patients also have pain, fever, nausea, vomiting. But again, ultrasound will help to differentiate. Another common differential diagnosis can be ovarian torsion. But again, in ovarian torsion, it can be seen in ultrasound. A patient will be a known case of ovarian cyst. And on ultrasound, enlarged ovaries will be seen. Enlarged ovaries is a typical sign of ovarian torsion. And also remember, even a pregnancy with fibroid degeneration. We know that in pregnancy, fibroid undergoes always red degeneration. So even that can be a differential diagnosis. I hope it was helpful for you. Thank you.